Aneurysm morphology is important. There are two types, generally fusiform and saccular. Why this is important is you may get this back in a radiology read of a saccular aneurysm, but it's small in nature. And you may say, you may have it in your mind, oh, they have to be 4 or 5 centimeters before we have to do something. But fusiform aneurysms are uniform, symmetric. They have a more predictable behavior. All the size criteria and rupture risks are based off of fusiform aneurysms, and they sort of follow that size criteria. Saccular aneurysms, though, are less predictable. They're asymmetric, they're more aggressive, they don't follow the size criteria, and they can rupture, sometimes unexpectedly, even at smaller sizes. So the initial workup for something like this is really just kind of a screening in nature. Certainly, if you pick it up on an imaging study, at that point, you're probably going to get somebody from Vascular involved. But then you also want to, when you're talking to the patient, if they relate to a family history of aneurysms, you want to talk to them about smoking history. And certainly, if you're over the age of 65 and have any tobacco history, you are entitled to an ultrasound screening of the aorta, just to see if you may have it. Or if you're over 60 and you have a first-degree relative with an aneurysm, you can also be screened. Knowing about any prior bowel surgery is important, more probably in our office than yours in terms of surgical planning. That may change what you end up offering the patient. Physical exam, pulsatile abdominal mass, you typically feel it just a little bit superior to the umbilicus and to the right. And you'll feel it. Now in thin patients, if you push hard enough, you can feel their aortic pulse. But if you feel one and you're not accustomed to feeling it, there's probably something there. And it's also very important to check peripheral pulses because aneurysms can be associated with pulses elsewhere. So making sure you're checking femoral pulses and checking popliteal pulses as well. Visceral vessels, association between aortic aneurysms and aneurysms, in the visceral circulation, that's not as direct. You may pick those up incidentally on a CT scan as well. But really, peripheral vessels, if you look, up to 14% are associated with a AAA, and what that means is if you diagnose somebody with a AAA, 14% may have an aneurysm somewhere in their periphery. 62% who have a popliteal artery aneurysm will likely have an abdominal aortic aneurysm. So maybe you haven't felt anything in their belly or seen anything, but maybe they're complaining when they cross their legs. They can feel some pulsations behind their knee. You examine them, they have a prominent pulse. You get an ultrasound, it's not a Baker's cyst, it's a popliteal artery aneurysm. Right there, make sure you check the other side and make sure you screen their aorta. And that association is even higher when you're talking about femoral artery aneurysms. So AAA surveillance, under 3 centimeters every 5 years. These are typically very slow growing. And as they get bigger in size, you want to screen them sooner. Greater than 5.5, you want to talk about elective intervention. That's the size at which surgery, the risk of surgery and the risk of intervention is much less than leaving the aneurysm and watching it. In females, you may want to consider over 5 centimeters. And it's important to stay consistent with the imaging study. So if you've been ordering ultrasounds, then order ultrasounds so you can compare apples to apples. Next steps and when to intervene on abdominal aortic aneurysms. Any patient that has a leak or a rupture is going to have acute onset abdominal pain radiating to the back. It's going to be different than maybe chronic back pain that they may have. They may feel lightheaded or dizzy. These patients obviously need care immediately. Patients may have embolic phenomenon, so they may wake up one day and say, I woke up this morning and my toe was discolored or it's blue, and it's isolated to one of their toes. And that really has to do with buildup of what we call mural thrombus or thrombus inside the aneurysm. So, blood that doesn't flow tends to clot. As the aneurysm gets bigger, the blood along the edges of the aneurysm flows slower and can clot and can build up. Does not necessarily mean you need to start the patient on an anticoagulant. They definitely need to be on an aspirin. It just means that repair are at risk for what we call embolic phenomena. So some of that clot's now embolizing down to their feet. And that's definitely an indication to intervene, even if their aneurysm may not be 5 or 5.5 centimeters. Saccular aneurysms are sort of case by case. And then rapid growth. So, if you're following somebody with a AAA in the office and you do an ultrasound and you get a repeat ultrasound and it's grown pretty quickly, that can be a rapid growth, and that could mean that that aneurysm is a little bit more aggressive and may need to be intervened sooner. So typically, when you get over 5.5 centimeters, we're up to like 20 to 35% rupture risk per year, and it goes up as it gets higher. Women, patients with COPD, transplant patients may have a low threshold for intervention. So you really want to stay on top of these patients as well. At this point, you're probably making a referral to a vascular specialist. And the way we treat these aneurysms is there's two different ways. More becoming the standard, and more what we do now, if anatomy is favorable, is the endovascular approach. This is minimally invasive. It's often without any incisions at all. If so, maybe tiny incisions at one or both of the groins. Faster recovery time. A lot of centers out there are talking about same-day AAA surgery. You come in the morning, you get your AAA fix, and you go home the same day. It is indicated even for ruptures. You do have to have a protocol in place at the hospital. Long-term surveillance is required. When you put in these stent grafts, they do have about a 10% chance over the life of the stent graft to have some issue, be it leak or slip. And so when you commit down this road, you have to tell the patients you're going to be friends for life and be seeing them back for multiple CAT scans. And as I mentioned briefly before, if they've had prior bowel surgery, prior bowel resection, when you put in these stent grafts, by definition, you are covering one of their mesenteric vessels. And so if they've already had some bowel surgery in the past and already have one vessel or some vessels or collaterals compromised, you can leave them with bowel ischemia after putting in a stent graft. And then there's a standard open approach. This is just a little schematic of how we do this. We bring the patient to the operating room, we prep out their groins and their abdomen, and we basically are inserting these stent grafts in through their groins. As you open them, basically you are excluding blood flow into the aneurysm. It's not going down to these stent grafts. So because these are modular in nature and because these aren't necessarily fixed with suture, you can see how over time, in some cases, some of this can slip or these can separate, and that's why patients need to be followed very closely. The open repair, typically if I see a patient that's under the age of 65, I tend to favor this, and the reason being is because, God willing, they have many years still ahead of them. It's a lot of follow-up still. But really, why we would do open repair tend to be younger patients, patients who have unfavorable anatomy for endovascular repair. So back here, you need to have some normal aorta, although now we have special devices and we have stent grafts and different techniques where we can pretty much fix aneurysms all the way up into the chest endovascularly. People who have other aneurysms involved, or people who may have long-term follow-up. I've had patients that live out in the country, and they come to you and they just want to come for their surgery and maybe one follow-up and go back. So they're not somebody that you may want to put a stent graft in and commit them to lifelong surveillance. And the way we approach these surgically, either through the abdomen or through the retroperitoneal space, and we reserve that for people who we need to get higher, or people who've had a lot of surgeries in the abdomen, and getting into their belly may be difficult. So another common thing that you may see in the office, patients complaining of wounds, cold or discolored feet, leg pain, and it's important to sort of identify the etiology because these are generalized complaints that can mean a lot of things. Some of them can be non-vascular in nature. First thing is can they be arterial? We're talking peripheral arterial disease, venous in nature, venous insufficiency. Some patients have a mixed picture, and then non-vascular origin. So you have neurogenic issues or musculoskeletal issues or lymphedema, something like that. Sorry, it's a little tough. So, initial workup for PAD, a lot of this is history. And I think that's where it really comes down to. You can pretty much figure out by the end of your first visit where patients have the issue and what you're going to offer them. So it's really critical. You want to ask patients about claudication symptoms, cramping in their legs necessarily related to walking, relieved by rest. Some patients have diseases in multiple levels, and they have pain without walking. We call that rest pain, typically in the furthest point of their heart, which will be their toes, numbness and tingling. And then looking at their medical risk factors that may result in poor healing. So, diabetes, hypertension, hyperlipidemia, smoking history, renal failure, poor nutrition. Presence of wounds, where they've been, or where they are, how long, are they healing, are they not, how they get them, whether it's traumatic or ischemic in nature. Ischemic wounds that happen in the absence of trauma purely due to lack of blood flow, again, are going to happen furthest from your heart at the tips of the toes. And then just having an idea if they've had any elective, or if they're planning on having any type of elective surgery of their foot. We certainly do see patients that may have like a bunion or something, or may want some foot intervention or some ankle surgery, done, and they may have some concern for PAD. So we'll see those patients and make sure that if they go for an elective surgery, that they're going to heal from that. Physical exam findings, quality of the skin and soft tissues. People who are ischemic, just the natural support tissue of the skin, the sweat glands, the hair, you're not going to see that. The skin can be dry, free of hair, and scaly and things like that. So just getting an idea of the skin quality. Dependent rubor, so you may see a patient, their foot's constantly red or beet red and swollen in nature. These are people that have significant peripheral arterial disease that only get relief by hanging their foot off the bed. They need gravity to get as much blood flow down to their foot as possible for relief. And why you get that dependent rubor is because those tiny blood vessels are so maximally dilated all the time, they're just to get enough blood flow down that they get engorged. Any infection on their foot, obviously any ischemic changes, any evidence of gangrene. And gangrene, I'll say dry gangrene, which is dry in nature, is not necessarily something that requires emergent intervention, but certainly can. If you see a patient in your office with dry gangrene, something very simple you can do is just make sure they swab that area with betadine daily, make sure they get in to see a vascular specialist or somebody to work them up. You don't want that gangrene to become wet, and then they become sick and infected, and then it becomes an emergency. Any concomitant swelling, lower extremity pulse exam, and then listening with a Doppler if you can. If you suspect PAD in patients, make sure the patients are an antiplatelet and a statin agent. Typically anyone between 18 and 75 with these risk factors should be on these agents. Screen for coronary artery disease. A lot of patients come to us for leg issues, but what they really need is to see, get their coronary artery screened as well. Screen for carotid disease, and then having the patient get a non-invasive lower extremity study. We do either, you could do even in the office, check a blood pressure at the arm and one at the ankle, if you have one of those automated machines, and you can divide the two and get a basic ankle brachial index and give you an idea of what's going on. Or you can send to the hospital or to a facility to get formal ABIs or toe brachial index, which I'll explain, and then you can get bilateral